Um, we are very interested in understanding PXE as thoroughly as we can. And so we're going to ask you over and over and over to make sure that you're registered in the registry platform, that you've taken the surveys, that you've connected your electronic health record. If you live in the US, if you're in other countries, we're working on those connections right now, because every single person contributes a piece to the puzzle. And you've heard me say that over and over and over. And I may be preaching to the choir, although I suspect a few of you haven't registered yet. And the important thing here is the example I gave last night at the kickoff was, if we had a room of 10 people, 2 were men and 8 were women, and we passed out a survey and only the 2 men turned it in, the result would be that only men have PXE. We all know that's not true, but the other 8 people, women, didn't answer the survey. So we don't know that any women have PXE. I could use any example. If we passed out the survey and the 2 people who had no vision loss answered the survey, and all the people with vision loss didn't answer the survey, we'd say there's no vision loss in PXE. So right now we're still saying a lot of things that we don't have the complete picture for. And over the next year, it's going to be really critical we get the full picture. The reason for that is 2, maybe 3. One is we can't really serve you very well, which is our mission, if we don't have the full picture. And so we need to know everything that you're experiencing and what we might offer in terms of support. Those of you on Facebook know that there's often lots and lots and lots of symptoms put on Facebook. Are they all PXE? Probably not. But until we hear from all of you, we won't know, is it true that they're not? A good example is 10 years ago, 15 years ago, we heard from women that they were having a biopsy every time they had a mammogram. We didn't know that actually microcalcifications in the breast was part of PXE. And it was the women who told us that, so that then Lionel Berkovich and others could do a study to show that. Same thing with testicular microlithiasis in men. We didn't know that until we did a study of men. We don't know what to study till you tell us. And so that's one reason. The next one is the progression of this disease is important in understanding how to slow the progression or stop the progression. And so we need to know what's affected and how is it affected, and that is an important piece. We'll be doing something called a natural history study in 2022, and that will require all of you to tell us a lot. Also may require that you do certain measures about certain parts of PXE and its advance or not, or its lack of advancing in you. And then the third reason is we are actually in a very exciting age finally, and that is there are a number of potential treatments for PXE finally. You know that up till now we have had just about nothing except to use or borrow things from other conditions, and we actually have some PXE specific treatments that will be talked about tomorrow during the research section. Some of you heard about some of them already. They don't really have a true measure. The measure is called a biomarker. And the example here is if you had high blood pressure and the doctor gave you a medicine, what the doctor would do is measure your blood pressure to see, is the medicine working? And that's a direct measure. They would change the medicine if it wasn't working. But in PXE, there's nothing to measure yet. Yes, we all know skin's affected, eyes affected, maybe vasculature, and especially in the legs and arms is affected, but there's nothing specific that we can measure yet. And so we're trying to find a good measure of whether or not a drug will work or a treatment will work or an intervention will work. And there's no way we can find that until everybody that we possibly can get can participate. So I'm going to switch to some slides and give you a little bit of an overview of some of the stuff that we've been working on in the past year so that we can understand better what we're doing. Okay, so maybe Matthew or Tamara or somebody, you can unmute and tell me if you can see the slides.
Currently seeing your presenter view. Oh, no, it's the good one. There you go.
Okay, yep, that takes a second. Sorry about that delay. Okay, so PXE International was founded in 1995, the year, actually a couple months after my 2 children were diagnosed with PXE. Unfortunately, you would have seen Ian this morning. You've seen Elizabeth in the past at meetings. The Diagnosis was made by Dr. Lionel Berkovich, who will be following me on this morning's presentation, this afternoon, this evening. And the kids diagnosed, little was known about this condition. It was then about 100 years old. It had been described 100 years earlier with this kind of mishmash of a name of pseudoxanthoma elasticum, which we could talk about another time. But anyway, we really felt that it was important that we not only a biobank, that's a collection of blood and tissue and so forth. We created a genetic test. We found the gene with Dr. Yoni Uto and Dr. Berkovich and quite a few other researchers. We published on all of this, and now we're in clinical trials, and you'll hear about those shortly. It's important in the sense not so much what has PXE International achieved, but that we've been able to put together a pretty comprehensive program that includes you guys as the people we really need to hear from that will drive this research and figure out what directions we should go in. It's a great day for us to be this far. We years ago would sit at these meetings saying we wish we were like other conditions and had some kind of drug or intervention in the pipeline, and we didn't. And so we're really happy to be here where we are right now. I'm also the, sorry, my cursor's running wildly. I'm also the CEO of something called Genetic Alliance. And while that's not especially relevant to PXE, it's important because I actually have the advantage of sitting in a seat where I see and work with and help to run 2,000 advocacy organizations. And so we can take the best practices from all of them and use them. We can take the tools that Genetic Alliance has created and use them for PXE. And for example, that led to my giving a TED Talk that has more than 1.4 million views. And in it, I talk about PXE. So pseudoxanthoma elasticum has been heard by more than 1.4 million people as a result of the broader work that I do. And so I'm really happy to be able to work for Genetic Alliance and PXE International so that PXE gets all the benefits from Genetic Alliance. I've written a number of papers on how people should be in the driver's seat. And I love that I can give as an example PXE, because you guys have stepped up and have done the surveys and have participated in various studies that we've done and in focus groups and all sorts of stuff. Ian would talk a lot more about the kinds of things that you guys have helped with, everything from creating the website and so forth, that we're in a position now where our thought leadership is driving the field. So we are really called on, and particularly these kinds of papers I've written to actually pave the way for other groups to take the reins and to be kind of the boss of their own disease and figure out where it is they want to go in terms of treatments, et cetera. There'll be a very big announcement on November 16th, where I, as Genetic Alliance, I will be given this massive donation to even push some of this farther. And again, PXE will benefit from all of that. So as we start to try to understand research needs, again, I'm coming back to, we have to count you all. Everybody has to be counted. You count, you matter. And so we have now 14,000 people registered with us, and that includes affected individuals, carriers, so their parents essentially, and other family members. We have 4,855 affected individuals registered with us. That's 300 new people in the last year. We've had a real surge. Things like Facebook and Twitter help because younger people use those technologies, although Facebook certainly is falling out of fashion for the younger set. There's 2,000 people with PXE in our Facebook group alone, which is quite good. We have another, in this group, that about 70% is female, 30% is male. A little bit of that skew is because males are less inclined to use places where they register for support, but we also know that PXE seems to affect females more than males. Why? We have no idea. If we had more people register and answer the surveys, then we would be able to tell. So again, we're going to be looking for lots of involvement from you over the next year. We have 5,600 specimens in our biobank. That's everything from DNA to tissue. And we're really grateful to the many of you that have participated in our genetic studies over the last few years. And 400 people have connected their electronic health record. This is USA only right now. We have pilots going in UK and Canada and are looking at other countries. The United States, during the Obama years, created a system whereby all the electronic health records in the United States were distilled into one set of standards. This is not unlike, for those of you who are as old as me, or maybe even a little bit younger, when Visa and MasterCard came out, they did not interoperate. You had to use a Visa at one store and a MasterCard at another store, Visa at one bank, MasterCard at another bank, and then they became interoperable. They spoke the same electronic language. And so now in the US, the EHRs all have the same language. It's called FHIR, but that's not important. Anyway, our system that we're using for the registry connects 700,000 portals in the United States. So there really isn't a portal we don't connect to in the US now. And so when you register, you'll be asked to connect your electronic health records from all the places you've been, the emergency room, the Minute Clinic, the local walk-in clinic, your primary care physician, your ophthalmologist, your cardiologist, your dermatologist. All of them are using electronic health records, and they can all come to one place and you can see them all in our system. So that's a benefit to you. We get the benefit because then we can, with your permission, because again, you get to give permission or not, look at your electronic health record and see what about when people get an anti-angiogenesis shot? Are they receiving betadine? What is the rate at which they're coming in to have those shots? Does that seem regular? Does it seem irregular? Is it one eye or the other, and so forth? All that we still don't know a lot about, but we will begin to because of the connection of these EHR. Any researcher with what's called an IRB approval, an institutional review board approval, can come and use these data. So here's a little bit of data that I did snag from Ian before his internet went down. You're looking at what are people's age at diagnosis. And again, because some of you guys have low vision, I'm going to read a lot of these. And all this chart is saying is that the vast majority of people are diagnosed between age 21 and 30. The next most common time to be diagnosed is 11 to 15 years old. The next is 30 to 40. The next is 40 to 50. Under 10 is a small number. 16 to 20 years old is a small number. And several people didn't answer, so it's not applicable. And then very small numbers are diagnosed in their later years, 50 and older. This doesn't surprise us in a way, except that this number keeps coming down. When we first started to do this, people were being diagnosed later. And now I think both because of our awareness raising, plus the difference in technologies like genetic testing, et cetera, we see larger numbers diagnosed earlier. That certainly is the reason we have this bump of between 11 and 15 years old. There's lots more data like this that Ian, again, will show us in a webinar later on. This is also from Ian, and again, this is too small for most of you to see, so I'm going to read a bunch of it. This was the study where he asked, how do you manage your PXE? And what you told us, because again, there's not really a way to manage PXE. You're borrowing stuff from other conditions, recommendations for your doctors and so forth. And so what we're looking at here is that most people said that they were using an Amsler grid. So 70% said they used one, 30% said they did not. That's that grid with the horizontal and vertical lines on it to tell you whether or not you're having some distortion and you need to get yourself to an ophthalmologist as soon as possible. We asked, do you exercise daily? 65% said yes, 35% said no. Pretty good percentage. It's going to be interesting to see if that's true across the whole PXE population. Heart healthy diet. Here we have 38% saying yes, 63% saying no. That's probably one of the best ways to slow PXE down, and every other disease, is to eat well. So that's something that we'll be looking at how we can support you to do that. And 93% said they went for ophthalmology visits, likely a retinologist. You'll hear from Wayne Fuchs later on today. And that's an important part of managing your disease. We talked also with you about the effectiveness of that, and I won't go through that. But suffice it to say that there was a lot of data coming in for us to look at to see how can we better support you, what more education would be useful, and so forth. And then we asked you, what things did you want us to focus on? And certainly eye disease was really high, heart healthy diet was high, exercise was high. And so we will be looking over the next year at what we can do to support you in each of those things. This is interesting. The average age of the non-legally blind person, sorry, again, my screen is very sensitive, is 50 years old. The average age of the persons who are legally blind is 61 years old. This number was about, so right now we have about 22% of you reporting, so only 118 people answered this. So again, you can see if the whole 4,800 answered, this number might be different. When this 118 people answered, 22% said they were legally blind. This number was about 35% in 2011 in a younger cohort. So what we're seeing is that less people are legally blind. That's not surprising when you think around 2008, 9, 10, we started to see the anti-angiogenesis drugs come in. They were in widespread use by the mid-2010s, 14, 15. And so less people are legally blind. If we exclude people who would not have had access to anti-angiogenesis drugs, so if we take out of that legally blind pot people who never had a chance to have anti-angiogenesis like Avastin or Lucentis or Eylea, then it's only about 16% that are legally blind. And most of those, it turns out, have dry macular degeneration for which we don't have any treatment anyway. Again, Dr. Fuchs will probably talk about that. And so what we're seeing is a much, much better prognosis for people with PXE than there were years ago, largely due to these anti-angiogenesis drugs. When we look at intermittent claudication, now that's the fancy term for pain in your legs after you start walking. This is not pain while you're sleeping or restless legs while you're sleeping. Those are different conditions. This is when you start walking, a few minutes into it, pain and cramping in your legs. So 28% of you reported symptoms of intermittent claudication with an onset of around 38 years old. This was half and half, men and women, pretty evenly. And so what we're seeing here is that intermittent claudication is part of this condition, but 75% less, 72% are reporting they don't have it. Again, we want to get more of you to answer because we want to make sure we have a clear picture here. In stroke, 5.6% reported having a stroke, 60 years or older, the average age of the first stroke. So this again is 6 out of 100 people reported a stroke. Much earlier in men, average age is the same in both men and women. And again, we're seeing mostly in women, but again, the cohort is skewed toward women. So this system that we're inviting you to allows you to connect even things like your 23andMe or Ancestry data, if you have it, or any gene panels that you've had done, your electronic health records in the US. Again, we're working on other countries. You guys in other countries don't have a unified system yet, except within the country. Surveys, the surveys are important for us to capture how it is you live with PXE, what's your experience of it. And then we're inviting you into studies. So some of you were pre-screened for the biomarker study using this system. So you actually entered your data into surveys here. And again, we're really looking forward to lots and lots of people doing this. So our successes so far as a result of the registry are genotype phenotype analysis. And what that means is that we are looking at if your mutation is such and such, does it correlate with us being able to predict how your disease will go? The answer is so far no. We don't know though, as we start to do more and more of these studies, and you'll hear about those tomorrow as well, are we going to start to see some ways that we could either predict or actually help us figure out how to treat your condition, your particular flavor of PXE? Because as you know from talking to each other, you don't all have the same experience. As I mentioned before, mammograms and testicular microlithiasis, where we found enough information to be able to have you take to your doctor a little bulletin that says, don't worry about these particular kinds of calcification. If you see them, it is not a precursor to cancer. We did a study on pregnancy, collected data from pregnant women, hundreds of them, and showed that despite the next one here, placentas being calcified, the mom and the baby had no problems in PXE. There's no need to do a C-section because of PXE. And again, this is very helpful to young women who had PXE, who have PXE, and are looking at having a baby. And kidney stones, we recently published that paper with Dr. Guido, PXE, and his group worked on this, and we showed that in fact kidney stones are more prevalent in people with PXE. In process, we've been looking at the effect of something called pyrophosphate on PXEers, and you'll hear about that during this meeting. We have the biomarker study, which you'll also hear about, which is this study where we're trying to find a measure, like I described about being able to take blood pressure or being able to measure cholesterol. We don't have a measure that's effective yet, useful yet in PXE. So the upcoming studies that we'll be looking at this year are a natural history study. We'll be asking you a lot about how you live with PXE. PrEP before eye treatments has been a major issue. Many people asking us, is there a way to have an eye treatment that isn't so painful, and that there are different techniques different retinologists are using? Dr. Fuchs may be able to speak to that as well when he speaks. But we're in fact surveying all of you and asking what happens when you go and have an injection, and then starting to understand what's working and what's not for you might be an interesting study. We're going to do what's called a patient-focused drug development meeting. That's a meeting that the FDA highly recommends. That's the body in the US that approves drugs and vaccines, as you've heard lately a lot about them approving the various COVID vaccines. That meeting will allow us to be able to tell the FDA what you care about. And as drugs start to come to the FDA, they like to know that so that they can see whether or not the drug is actually meeting your needs. We'll actually do a study on physical exercise. We're working with Fitbit to see if we can get Fitbits for folks to be able to track the data. And then we're also working with several industry partners. We're offering things like connecting the EHR and the patient-reported outcomes, PRO, recruitment, screening, consenting, and so forth. So all of that is upcoming. I will just interject here because we won't talk about it at length. We've gotten a lot of questions about whether you should have the COVID vaccine. The answer is yes, and you should have had it a year ago. So go for it. There is no bad effects of the vaccine with people with PXE. There are horrible effects of getting COVID and of getting long COVID. So get the vaccine, get the booster, and so forth. And as the ages come down, make sure the little ones around you are also vaccinated. That's going to be a very, very important thing. We've lately had quite a few friends getting COVID, and then several deaths in the community. So we want to make sure that you're vaccinated as soon as it's offered in your area or region, which you should be in most places at this point. Again, I mentioned this, we have a consortium working together. All the researchers and clinicians you see over the next couple of days are part of this. They've been helping determine what is it that we want to try to measure so we can figure out the right measure for PXE in any kind of clinical trial. And I want to thank you, the people living with PXE, because while all the researchers are doing fabulous work, it's actually you who are contributing the most to this work. And I definitely want to thank our staff, some of whom you see here today, some of whom are either not here today or actually not with us anymore because they've gone on to other jobs. So I'm going to stop sharing my screen and open it up for a little bit of conversation. If questions are specific, around a specific organ system, then what I'm going to do is wait until we get to that clinician. And I'm certainly happy to jump in at that point as well if they need my help. They often don't. And so we'll wait and look at those later. A couple questions I got while we were speaking is how about this electronic health record connection? Are they anonymized? Do they have different security levels, et cetera? So I'll explain very briefly our registry system, and then we have a couple webinars on it that we've offered, and we'll offer some more. And then Mary offers direct hand-holding, and sometimes Matthew, for the electronic registry system. So when you register in this system, it's like registering for your bank. So, you know, when you go to do online banking, it sends a code to your phone. That's called two-factor authentication. And so this system that we're using uses the highest security system like that. It also uses the highest privacy systems in the world because we're international, and the European Union has passed something called GDPR, which is a very strict privacy regulation, which requires that you always get to decide what's being done with your data. You might have noticed lately that every website you go to says, we use cookies. Do you want to fix the cookies, or do you want to let us use the cookies? Do you want to take your data away? Do you want to leave your data here? Do you want this app to track you all the time, or just while you're using the app, or never? And so that's the kind of things that are built into our registry system. Then we get to the EHR. So they use this thing called a standard, which it's similar to saying, you know, if in the US we had different plugs in the wall, outlets in the wall, and then your plug didn't fit in it, it would be awful. And the standard is the same across the US. The standard is not the same across the world for these electrical outlets. You know that if you've traveled anywhere, they're different in different countries. The country has a standard, but it doesn't interoperate. And we get adapters and we make it work. And the same thing's happening with the electronic health record. In the US, there's one standard now, and they all come into our system. They're all de-identified. That means we take your name off of it. You see it with your name on it. The researchers do not see your name. And so when you're in our studies, the researchers do not see your name. The EHR, the electronic health record, doesn't have your name on it. But if you decide to participate in a study where we send a nurse to your house, then they're going to see your name, because they're going to need to know your name, your address, your phone number. And in that case, either PXE International is managing that part and we're sending the nurse to your house, and the company or the academic group doesn't see your name still, or they also are involved and see your name. You know this because if you've given us blood, for example, for the gene studies that Dr. Yuto has recently done, he doesn't know your name. He knows a code number. We know your name because we sent the phlebotomist or the kit or whatever it was to your house. So that's the deal there. The other questions that I've been getting are pretty much around specific organ systems, and I'm going to wait and have the clinician or the doctor who's an expert in that area take care of those questions. My staff is tracking them, and we will be making sure that you get answers to them. Any other questions on what PXE International is doing, what we're doing to prep for research, what we're doing to support you, not specific to a organ system?
Sharon, I have a question since I'm fairly new both to the diagnosis as well as this group. If I think there's a lot that I didn't complete. I didn't do the survey. So I'm just wondering if there will be information for those of us who are new to both the diagnosis and this group.
Yep, thanks, Gopi, for the question. The old timers here will tell you that Sharon Terry badgers them unbelievably. I phone you, I email you, I send letters to your house. I'm short of sending you all flowers. We're about to start a calling campaign because, again, of the almost 5,000 people with PXE, only 400 have connected their electronic health records. Only 1,000 have registered. So you will hear over and over and over again. Each time a new survey comes out, each time we have something new coming out. So absolutely, it is probably the thing we say the most. Every single newsletter will have it. And even though you just registered, Mary should have sent you the latest newsletter, so I'll check with Mary about that. And in that, it will say, have you registered for the registry? And here's the surveys. Yep,
Okay, thank you.
you're welcome. We'll be looking for volunteers for our calling campaign because there's no way Mary can call 4,000 people. So we'll be also asking you for help doing that.
If we've got new doctors, how do we update your connection so that their type of VHR actually is now being reflected? I seem
Yep.
to get new doctors every now and then.
Of course. So everybody, you might go to the walk-in clinic this afternoon, God forbid. You may have a new doctor. Those sorts of things are important. So yes, every time you go in, you can refresh your EHR if you want. If it's still the same, you don't need to touch it. If it's new, you just add your new doctor. Liv, you're saying we should set up a screen share. So we did that last time at this meeting. What we're doing instead is having separate webinars on that. And so we will do that again. We do that pretty regularly where we have tutorials. We also have hand-holding sessions. So Mary calls you and she screen shares and she walks you through yours step by step. And so that's also available. Again, 1,000 have done it. 4,000 have not. That's a lot for Mary to take people through. And so we're looking for ways besides webinars and handholding that this will work. Gretchen,
How
you
can
have
we
a question.
volunteer to help?
Hey, Bob, just hang on a second. There's a question from Gretchen, and then I'll get to you. Gretchen?
It's sort of a two-part. Some of my record, having living with this for 20 years, some of my initial diagnostic records are pre-Epic, and I'm just wondering about if there's a process or a recommended process, because when I connected my records to the system, obviously it's only my most recent, which happens to be a part of a university network. So it's all nice and compact in one place. But because I've lived in 2 different states in the last 20 years, getting some of those initial, is that I'm just wondering if there would be an efficient process for doing that, because I'm guessing that some of that would be helpful as well.
Yes.
The second question I had is, and then I'll shut up and let you answer. The second question I had is, I noticed during the survey process that, and I don't know if this would be helpful or not, but there wasn't any sort of space for anecdotal type stuff. Just because when I had my daughter back in 2007, I wasn't a part, I had very limited internet access. I wasn't obviously a part of the pregnancy cohort, but I did have, even though my pregnancy was quasi-normal and my daughter was quasi-normal and the placenta was not calcified, I had I had eye flare-ups during the entirety of the pregnancy. So that was a complication, made it high risk, and I did have to have a C-section for that matter. So even though it's not quite within the parameters of the information, I was just wondering if that would be helpful anecdotally, and some of these other things, I'm sure that there are anecdotal things that go out there as well.
Yes, yeah, 2 good questions. So for the first one, records that predate the electronic systems, we ask you information about those via surveys. And so we depend on you to fill those in. So when were you diagnosed? Who diagnosed you? What was your treatment before electronic health records came in? So we need those to be answered by you. We, in the old days, collected those records. Mary can tell you that we are in the process, because we are closing the physical PXE office. We're in the process of scanning records. We probably have, 12 file cabinets worth of records, and we have to scan them and take your name off them and so forth. We're not doing that anymore because the electronic health records are complete enough. So we're depending on you for the old information. The anecdotal information, there will be a survey, and I'm sorry that Ian wasn't able to come. And again, we will have our usual series of webinars throughout the year, and we'll be telling you about this. That stuff we will be collecting in a very big survey we're about to launch. The problem with that anecdotal evidence is that we then have to go through it and we have to standardize it. So everybody's story is super important, but now we have to distill it to data elements. And so what we'll do is we'll hear all the stories and then we'll create surveys whereby you can enter that information. So thanks for your questions, Gretchen. Shannon.
Hi, thank you. So the only two physicians I have who don't make my electronic records available to me are my retinal specialist and my dermatologist. If I don't have access to those through the usual portal, is there a way that I can go about getting those to the registry?
Yes, so it's illegal in the United States now for them to not make them available to you. So what you do is you call the office, Mary will connect with them and tell them that that's illegal. They will tell her that actually there is some convoluted way of getting to the record, and then she will hook that up with you.
Wonderful, thank you.
Yeah, we're
How do
happy
we
to help
volunteer?
anybody do that.
How do
And-
we volunteer to
Yeah.
to help Mary make phone calls? I've got a phone that I can call anywhere in the United States and doesn't cost me a dime, and I've got lots of time.
Great, thanks, Bob. So yes, there will be a call for volunteers shortly. We had hoped to do it already, except this meeting took us longer to plan than we thought. So you will hear multiple ways. We will put that out on our newsletter. We'll send emails to everyone. We will put it in our PXE chat online, the Facebook group. So there'll be lots and lots of ways that we'll connect with people to ask for volunteers.